Hi, everyone. We'll be starting in a few minutes. We're just admitting people. And just to confirm that we're recording this webinar, and the edited version of the recording of the video will be up on our website. So by switching on your video, you consenting to that or agreeing to that, or if you speak during the webinar, it will be a publicly shared video. Thank you. Okay, Andy, over to you.
Thank you very much, and good afternoon, everyone, and welcome to this technical webinar hosted by the Health Justice Initiative together with the University of KwaZulu-Natal. So the idea of this webinar is really to look at the implications for equitable access to life-saving and affordable medicines for all patients, having taken into account the adoption of the B version of the NHI bill by the National Assembly just on the 13th. So that B version has made changes to what was in the original bill that was tabled in 2019. So we now have a version that is moving to the National Council of Provinces for their consideration before it comes back to Parliament for the final passage. I was particularly struck today by a thought leader piece in the Mail and Guardian, which seemed to encapsulate the problem that we're all facing. And in this piece, Professor Benjamin Smart wrote, "The NHI is at its heart a noble idea. The challenge that we're facing is to try and move from that nobility to something practical and implementable." So today we are going to focus on the B version, what has changed from the A version, and particularly what this means for medicines access. So we're going to first ask Fatima Hassan from HJI to share her slides and take us through some of the technicalities. We'll then unpack some of those and open up for discussion for the balance of the time in the webinar. So Fatima, over to you.
Thank you, Andy. So I'm just gonna try and do this, and hopefully you can all see the slides. Yeah, thumbs up.
We can do, perfect. You can just put it on slideshow.
Is that what?
That's it.
Great.
That's it.
Thanks. So just want to thank Andy for moderating the session, and Fatima Suleiman and Marlies Richter, who are part of organizing this webinar and workshop series. Fatima is joining us from Rwanda, and Andy has some video limitations, which is why you can't see his video screen as well. So we're just going to go through a few quick sort of highlights, as Andy sort of indicated, to show you the difference between the first version that was introduced and then the version which is called Bill B, just to make it easier. That's been adopted by the National Assembly, and as Andy indicated, the still has to go through the process of the NCOP. For those joining from outside of South Africa, that means the National Council of Provinces. It has to go through a process through all the different provincial legislatures, and then it has to go to the president. But let's just take you through some of the development that has happened since the introduction of version A, the adoption of version B, and where we are right now. So you'll remember that last year, the HJI did an analysis paper on what was version A. A lot of it hasn't changed, and we'll go through the changes now. And our particular focus was around medicine access. So I just want to sort of indicate that the disclaimer to this webinar is that there are many issues that groups need to consider and focus on in relation to Bill B. We as HJI, and for this series of workshops with UKZN, are particularly focused around how will people living in South Africa, so that means people who are South African or even not South African, but all people living in South Africa, so to give effect to this noble idea of universal healthcare, be able to access medicines in our country at the right time, at the right price, and in a very transparent way. So, and how will that system actually be managed or merged or regulated or coordinated? So our focus is a very narrow one in this respect for this webinar series, and that's on Medicine Access. Now, assessment on version A was that it wasn't clear and that it hasn't been adequately thought through, and that we actually could face a medicine access crisis if it's not addressed. And unfortunately, we'll take you through the slides of what's in version B. We believe that that assessment still holds on the version that's been adopted by the National Assembly. So our concerns are very different, are very non-partisan, and are different to the issues that opposition parties are raising and the issues that some commentators are raising. Our issue is around how do we go forward with a transparent single medicine access and pricing system in South Africa. And basically, far from being this revolutionary piece of legislation that the minister claims it to be, we believe that it's actually very far off the revolutionary mark, and could actually worsen the idea of social solidarity instead of giving effect to it. So part of the webinar series is that we've had the first one already. You can listen to all the presentations, which included Fatima Suleiman, as well as Andy Gray, and Discovery Health as well. And those were presentations made on the basis of version A of the bill. And you can find that on our dedicated National Health Insurance page on the HAI website. We'll be following this particular webinar with 2 additional webinars, one in July that's going to focus on monitoring and evaluation aspects in relation to NHI. And then in August, where we want to have a solution lab, where we want to find technical solutions and suggestions around how to actually merge systems, how to create coherence, transparency, and to ensure affordable and timely access for everyone. And that really is with a view to the current process that is underway, which is around the provincial hearings and what will be happening in the provincial legislature. So we'll come to that later. So there is a possibility that we may move webinar 4 earlier to July if there's an opportunity to actually try and influence some of the provincial hearings and processes. So things are moving at this stage quite fast, surprisingly. And following webinar 1, the bill B, as mentioned earlier, was adopted by the National Assembly. Okay, so this is meant to not be clear, the slide. But this is how we understand the bill currently, bill B. So if you read the bill, our understanding, and we've gone through the different bills, we've gone through the changes, we've gone through bill B, which is now 60 pages in length. And the future of medicine access under NHI, and this is reflected in the op-ed we wrote last week, just before the bill was adopted, was around this idea of 4 parallel systems operating at the same time under NHI. Now, this is how we interpret the bill. We believe that the bill is not clearly drafted. At some places it's confusing, at some places it's ambiguous. But our best interpretation of what is being presented, or the signpost for the future of medicine access under the NHI, is this. We could be incorrect, we could be wrong, but that actually requires government then to do a better job at explaining things, and to be honest, not to be so defensive about what has happened. And remember, this is in the context of 2 different legal opinions that were actually given on version A of the bill, one from the state law advisor and one from the parliamentary legal advisor. So unfortunately, depending on who you speak to, and depending on who you ask for information in the department, you may get different answers. And even lawyers that work for the state can't agree on certain interpretations. So that already is a red flag for the potential for decades-long legal challenges against the bill. A lot of opposition parties have already indicated their intention to do that. In one case, Solidarity, which is a trade union, which is affiliated to the Freedom Front Plus, has indicated that they're already preparing legal papers, even before the bill is gone to the HMP. So there's a red flag in the risk of legal challenges. And I think it would have implications for us as to whether civil society and academics and researchers go in. I mean, that's on all of these different legal cases and how feasible that is. But our understanding of what's presented is that for a long time still, even with the NHI being adopted, there are going to be 4 systems. And that's the blue system, the orange system, the yellow system, and the black system. And we try to simplify it as much as possible. If we deal with the big blue block, which is going to be for the majority of people in our country, over 50 million people, this idea that NHI will be for all is actually not totally accurate. According to Bill B, it's for registered users, that's dealt with in section 5, and a registered user of the NHI fund is going to be somebody who has user status and a proof of identity, which has to be presented at every visit. The user has to be somebody who follows the referral pathway, so you can't just go from a clinic to a hospital unless there's actually a referral letter, for example, and the benefits will be determined from time to time using the structure contained in Bill B for what benefits should be, what their prices should be, which basically means that a user would only be able to access those services from NHI accredited providers. But here's where it becomes a bit more complicated. Within this big blue block of everybody is able to use NHI services, well, what falls under NHI, not quite. The SANDF and State Security Agency excluded from NHI, excluded from the MBIT, so they will have their own payroll system to determine what their health services are, to determine which medicines they want to use, which diagnostics they want to use, etc. And we already saw that with COVID. The second element of who gets to use NHI in South Africa, and this is, the result of years and years of systemic and institutional xenophobia, and more recently, really blatant xenophobia by groups, or vigilante groups, as well as government officials around people who are not South African, who are coming from other parts of Africa using healthcare services in South Africa, despite what our constitutional protections are. So here, the exception that's contained in Bill B is that asylum seekers and what they call illegal foreigners can only access emergency services and services that relate to notifiable conditions. In Bill B, illegal foreigner is not defined, there's no definition, but presumably they'll use the Immigration Act definition, which is a foreigner who is in the country in contravention of the Immigration Act and includes a private interest. So that's, we can have a whole webinar on that. That is going to be even more difficult around healthcare workers trying to ensure proof status or trying to actually be a parallel Department of Home Affairs unit within a health facility, simply unfeasible. And then important change from Bill A to Bill B is that it now includes that all children, irrespective of their nationality, and that's because of some really good legal work that's been done by Section 27 and other groups, and also because of the provisions in our Constitution. But now all children, even if they are children of asylum seekers, even if they are children of what's called an illegal foreigner, can access basic healthcare services as provided for in Section 28 of the Constitution. So that can also be open-ended and means a lot of us a lot of advocacy. Assuming you are a registered user and you do have proof of identity, and remember there's millions of South Africans who don't even have an ID document, what we call part of the undocumented in our country, you'll be able to access services at the point of care for free, but only services that are included in what's called a benefit list. There'll be a national health products list and a formulary, which at the moment it seems, according to this bill, will combine what's in the essential medicine list and the essential equipment list. And then it also has a really oddly drafted provision that providers and establishments, so these are accredited providers and there's a whole process of accreditation, must procure themselves per the formulary. So you'll start seeing that it becomes even more unclear and a bit more complicated. The second big block of services that are going to operate in parallel to NHI until some later time, and we'll come to that point of when the minister decides, that NHI is fully implemented. And then he will issue a declaration or a notice to that effect in the government gazette. And we think, Andy and I and have discussed it, we think that could be anywhere between 10 to 20 years, including if there are legal challenges by the private medical schemes industry itself, because the minister will have the discretion to decide whether NHI is fully implemented. So let's assume that day is 10 or 20 years down the line. For now, what happens if the NHI was to be adopted tomorrow is that medical schemes continue as is. They continue until the NHI is fully implemented. And when that day comes, when it is regarded as fully implemented by the minister, then medical schemes currently that exist in South Africa can only offer complementary cover. And this is the language of the bill, which also again is unclear to us, to services not reimbursable by the fund. So that's basically your top-up cover. Whatever you can't get from NHI, if your scheme offers it, then you're also paying an NHI tax or a surcharge, and you're also paying your medical scheme premium, you'll be able to get some top-up services that the NHI can't offer you, or medicines that the NHI can't offer you for a number of reasons. Could be selection, clinical selection reasons, or delayed use of a particular product, or simply affordability, which seems to be going to be the biggest issue as to why the state can't provide a timely life-saving treatment regimen. And so that could then be reimbursable by the medical scheme. So before I come to what's currently existing for medical schemes, I just want to go to the black block. And that is now the third way in which people living or working in South Africa is able to access health services or have to fund health services. The NHI fund that's going to be set up does not cover the cost of care for a foreign worker or a student who is not from South Africa, who has a valid, what they call short-term work or study visa. All right. So there's different provisions in the bill. If you align them, basically they're saying that a foreigner visiting South Africa, so it's a slightly different language from the earlier provision in the same bill around working or studying, they must have travel insurance, or else they only have a right to emergency healthcare and services for notifiable conditions. So we're assuming that this insurance product has to be offered by a non-South African insurance provider. It's offered by a company from where that person actually comes from. They're coming to work or studying in South Africa. They need insurance cover. So we're not sure of what the basic package of services they are entitled to, how that's going to actually reconcile with the insurance product. But that's a third way in which somebody would be able to access care. And then there's the yellow triangle, which is basically, you may not be a foreign worker or a foreign student. And sorry, I'm taking so long to explain it, but this is sort of the basis of the presentation. You may not be an NHI registered user, or you may not have medical scheme coverage, or you may have one or a portion of those three in any different combination. If your medical scheme cover is run out, if you can't access NHI in time, or there's a dispute around the referral pathways and you really need to get your medicine, you're basically going to pay for it yourself out of your pocket. And so there's going to be a FOT system, and the bill allows us, which talks about out-of-pocket payments as well. So if you, basically want to get something like a really new innovative cancer treatment or cystic fibrosis, your medical scheme doesn't cover it, NHI doesn't cover it, you're not entitled as a South African to have other insurance products, and basically you're going to have to pay for it yourself. Now, we're assuming, because it's unclear what the situation is for diplomats and embassies, potentially you could have a fifth system, we're not sure. So the diplomatic corps, and you remember in COVID, they were bringing in their own vaccines on their presidential jets, and they had preferential access to vaccines while we were also waiting. So this is an issue around what medicines and vaccines and diagnostics they would access, and do they access it before the general population in South Africa. But there's no mention of them. There's no mention that they're excluded in the bill or included, but we're assuming that if you read the definition of a foreigner visiting South Africa for any purpose, or you regard them as foreign workers, then assuming that they're going to have insurance products, and they potentially, if they have really great insurance, can then just buy up and buy up and buy up. So the implications of the Orange Bloc is that judges, MPs, the president, deputy president, cabinet ministers all belong to PARMED. And for at least a decade or two, we believe that they will just continue as they always have been, where the medical schemes will cover all of their services and they can get complementary cover the day when medical schemes can no longer provide sort of the basic services. And then just a final note about how this blue block is going to be funded or what money is going to go into the NHI fund. The way the bill is drafted is it's talking about multiple sources potentially of income. Remember, there's no money bill that has been associated with this. There's a lot of concern around the sustainability and also about the sources of funding in a context where there is high levels of corruption, more reports of allegations of procurement corruption in health facilities and in health settings, including assassination of a whistleblower in Gauteng who reported on irregular expenditure around health procurement and health expenditure. So that this is a concern. So sources are parliamentary appropriations, general tax revenues, scheme tax credits, reallocation, so that's from the Orange Bloc, payroll tax, as well as personal income tax surcharges. So I think what we also have to do is do some scenario mapping for a low-income worker who's regarded as an NHI user, maybe is on a low-cost medical scheme, like a basic level entry plan scheme. In addition to paying all of these different contributions and taxes, may still be in a position where they're having to make out-of-pocket payments for registered medicines. So I hope that is clear, because that this will sort of explain to you the remaining of the slide, or the remainder of the slides. And then just the final thing on the Orange Bloc is that, and it's something we discussed in webinar 1, was that there are current systems and there's also current data collection and information systems. And the question is, how are all of these going to be merged or managed or regulated? And a lot of this requires thinking quite in advance, but also clear signposts in the law, in the bill. Because if we wait for ministerial directives later or regulations later, I mean, we've been down this road before, that's not going to be very useful. So currently in the medical schemes context, and most of you know this, but this is the part at which we have to talk about alignment of what's going to happen when you're having these parallel schemes operating even under NHI. NHI will have this National Health Products List and a formulary, and will have a benefits advisory committee telling you what services are permissible and what services are not, based on a number of considerations for NHI. The medical schemes, if it continues to operate as is, now that's how we imagine this to play out for the next decade or so at least, is that they already have a set of prescribed minimum benefits for which there is alignment of what the state provides. There's about 200 plus schemes. We don't know if all of them will actually survive for the next few years, given what the implications of NHI are. Within those schemes, there are multiple benefit plans. So there's always an element of out-of-pocket, because not all benefit plans will give you all the top-ups that one can imagine. There's a pricing committee that deals with the single exit price system, with the SEP adjustments annually, with prescribing dispensing fees. So there already is that system. It's unclear what's going to happen to that under NHI while medical schemes, while the Orange Bloc still continues. There's also risk rating rules. We can't risk rate any longer. That was the important piece of legislation that was passed early on. And there's regulation around waiting periods and late joiner penalties. So the schemes can't just basically use the classic insurance principle. So the question is, if you allow a system then of one day having schemes that can provide complementary cover, we also need to ensure that the issues around waiting periods and late joiner penalties, you need a totally different system for that, because this is no longer the system in which we're operating, where people have an option, or it was their own what we call self decision making, or their own behavior that led to somebody joining the scheme much later. So I think there's a real socioeconomic issue here around what could be fair, what could be equitable, and how we redefine what we're going to actually do around the waiting periods and the late joiner penalties for people who then want complementary cover, or people who may now decide to take out medical scheme cover because they may feel, whether it's rightly or wrongly, that they don't want to use services through NHI, and they only want to do that through medical schemes. Okay, so let's just now, I'm going to quickly go through this because a lot of you can actually read through the bill. But these are just some of the key changes that we've picked up, because one of the critiques of many groups in civil society, as well as some of the opposition parties, is that a lot of the submissions were not listened to. There were thousands of submissions on the bill, and there's a sense that there's such a high level of defensiveness that there wasn't any material changes to the bill. I think that assessment is fair, but there have been some drafting changes. And so we thought we'd just highlight that because some of them are useful, some of them are relevant, but they don't go far enough. So what we now have is just a list of some of the changes in the bill. There's quite a few language changes and typo issues, so we're not going to go through all of that. We just want to highlight some of the bigger issues. There's a new definition for basic healthcare services, which practically, if you try and implement this, may actually create more issues because it's really unclear. And this is why we had mentioned this idea of the NHI list of the formulary, the PMBs, and also what the basic package of services are going to be, that's going to be recommended from this benefits advisory committee. But this is now the definition of basic healthcare services. So if you're a patient advocacy group or you're a civil society group, the advocacy here is making sure that the benefits advisory committee offers a package of services that is not going to dip below what is currently on being provided by the state, both to adults and children, and that there's serious attention being paid to a more regular change and a more regular increase in the type of services that could be provided. But if you have a situation of insufficient funding, or if you have a situation of real budgetary constraints, then how you define what good health is and preventing serious health problems, I think is going to be a continuous conundrum. And Andy will talk about this after I do the presentation. There's a new definition for health product. There's a new definition for supplier, and I think that's important because it talks about both the public and the private sector providing goods and services. And so this narrative in the last 10 days that the private sector will not be involved in any aspects of NHI, I think is also misleading and incorrect, because they certainly will be, and in fact there's a potential for them to have a greater market of health services in South Africa if they agree to be an accredited service provider, and if the state pays them on time. And then I think quite importantly and interesting is that the act or the bill is now also talking about directives issued by the fund, and that could become relevant later. So you're grouping that with regulations, ministerial directives, notices of rules, and then directives issued by the fund. So that opens up a whole sort of other set of legal implications and issues. Some very quick key changes or additions with in caps is where the additions are. Importantly, the application, and this was an issue raised about why the Competition Commission was excluded from enforcing any aspect of the Act. They've now clarified that it's only that the NHI fund is exempt from the Competition Act. It's a single purchaser and single payer, so not necessarily the contracting parties, which I think is an important amendment. We've already talked about including all children under population coverage. We've talked about the private insurance covering international travelers, so there's just some language around that. Where it is mentioned international traveler with voluntary medical insurance as well as out-of-pocket payments. Cost coverage, we've talked about that as well in the black and the orange and the yellow blocks. But what's important is that you will not be reimbursed for services not deemed medically necessary by the Benefits Advisory Committee, They've added in more language to make them more explicit. Services not covered by the fund as prescribed by the fund, or services that are not included in a package as advised by the Benefits Advisory Committee. We just wanted to highlight that because we think that actually the most important committee that's going to be set up here in this process to determine at the outset what benefits should be available to people, what medicines you can get, is actually going to be. And we'll talk about how it will be composed shortly and its powers. Some important changes, and I think we should welcome that, to the inclusion of cabinet in the decision-making process. And so cabinet has to approve basically the board members, the board chairperson, and the CEO of the NHI. So they're no longer leaving that as sole exclusive ministerial discretion. But the problem with cabinet deliberations and that process is if you want to challenge the appointment of members to the board, for example, there are groups currently really concerned about the appointment of the new health ombudsman. So if you want to challenge the appointment of board members, of the chairperson of the board, of the CEO of the NHI fund, and if this involves cabinet deliberations, there are obstacles to access to information requests because it's all be regarded as state secret documents and memos. So this is something I think we're going to have to pay a bit more attention to. Important change of another unit, which for us is going to be really relevant alongside the Benefits Advisory Committee, was initially called the Office for Health Procurement or something like that. It's now the Health Products Procurement Unit, alongside 8 other units that are going to be established in terms of the fund. So I'm sure there are groups here that are going to focus on the other units. This is the unit that we're really concerned about because it's a unit that's going to be responsible for negotiating and procuring medicines, diagnostic kits, etc. There's some language now around impartiality, the usual standard language, which is now repeated for all the committees of the board. Yeah, not a bad inclusion. And there's some conflict of interest provisions that have been fleshed out for the Benefits Advisory Committee and Healthcare Benefits Pricing Committee, and drawing on the lessons of COVID and some of the recommendations we were making around this issue. We think it's important, but it doesn't go far enough. It talks about internal disclosure of interest, and then the person has to be recused from discussions. But it doesn't mandate public disclosure. So if you have somebody sitting on a Benefits Advisory Committee and a Pricing Committee determining benefit packages, determining the prices of those particular benefits, we believe that any conflicts of interest should be publicly disclosed, and that the recusal also has to be publicly disclosed. Because again, like in COVID, we just saw multiple conflicts of interest operating at the same time. It's often unclear who was advising minister on who was advising the minister or government on what issues. At one point, we even had cabinet taking a scientific decision around whether to pause a vaccine or not. So this is not looking great. There's now a conditional accreditation included under the provisions on accreditation in section 38. And then, interesting thing around the appeal tribunal. So you can appeal any decision of the fund, which means a health user or healthcare workers or patient advocacy groups are going to spend all of our lives basically lodging appeals. It's a 5-person board appointed by the minister, again, in addition of the duty to consult with cabinet. And the appeal outcome is now 90 days, not 180 days. So you could presumably wait 3 months when you're trying to, there's no provision for urgent decisions when you're trying to appeal whether you use the correct referral pathway or whether you want to challenge a decision of a committee or any aspect of the fund. And then some slight changes to the phases, which is self-explanatory. And then this is the part which is confusing all of us, which Andy will talk about after I present, and that's related to what's going to happen to Section 22 of the Medicines Related Substances Act, and the SCP and the appointment of a pricing committee. So Bill B deletes the change that they had initially in Bill A to the SCP definition, but it now includes that the minister, after consulting the NHI fund, will appoint a pricing committee. So very confusing and very ad hoc, but Andy will take you through that shortly. So two important committees, we believe, for medicine access work, like I mentioned earlier, Section 25, the Benefits Advisory Committee. Again, the number of members are not specified, not a long section, but it's going to be recommending the services that should be provided by the NHI funds. I think it's a really important committee and it's going to have a lot of power. And then the Healthcare Benefits Pricing Committee. So we're going to have to, learn all of these new abbreviations. It's anywhere from 16 to 24 members, and it recommends the pricing of health service benefits. And well, we think health service benefits under NHI. And then purchasing dealt with in Section 35, which is direct payment reimbursement systems. And reimbursement is an issue we talked about in webinar 1, or the lack of prompt reimbursement. A contracting unit being established for primary healthcare, and then really significant, the newly named Health Products Procurement Unit, which will be located within the fund, which will also procure medicines. And the board, after consultation with the minister, establishes the unit. So the minister, cabinet, the board, you can see basically the ecosystem of how all of these things are going to be located. And remember, the Health Product Procurement Unit is just one of about 8 units. Interestingly or worryingly, depending on how you see it, the Health Technology Assessment Unit is not defined in any way. And again, Andy will take you through that, because there were initial indications that they would have an interim structure and it would transition, but it just, we've looked and we can't find anything on that. So next steps, and this is just sort of coming to the end. Obviously, more public transparency, one mandated sharing of all deliberations of the board, of the advisory committees, or else we're just going to be spending many years lodging access to information requests, where we'll be ignored, where we'll be rejected, and then having to go to court. So, just creating a space for just more litigious handling of health access related issues, which doesn't really serve public health or public health outcomes. But I think more importantly is we've got to, at the NCOP process and in the provincial legislature hearings, really push for more provisions and more transparency and clarity in the law at the outset on how selection decisions and prices on medicines, both under NHI and not covered under NHI, will be decided. What we're going to do with the SCP system, whether we're reinventing the wheel, how do we actually get to a single transparent system for equitable access to medicine? How do we regulate the prices if you've got these 4 blocks operating in tandem? And even if by some miracle you could merge all of this and have a single system, you still need to regulate that. And then also, the bill talks about strategic purchasing and how this unit is going to be just so super advanced and amazing, and it's going to negotiate with every single global pharmaceutical manufacturer and procure for the entire country. Really unsure how that's actually going to happen, given sort of what has been happening on HIV, on cancer, on a range of diseases, but also what happened in COVID. So finally, what happens now, and you can follow the PMG website, I just want to thank them for all the information that they've been sharing and keeping the public informed. But when people talk about a Section 76 bill, this is basically what it means. But in summary, it means that we now go to the provincial legislatures. They have to basically issue dates for input from the public to comment. We don't know if they're going to allow us to have public hearings or whether they're going to take participation, because there were provincial hearings before. But they've got to basically make sure that there's adequate public participation. And for us, this is important because what we really need to argue as civil society or as groups really concerned about the future of healthcare in South Africa is that we need to use these processes and these provincial hearings basically to ensure that the technical aspects of Bill B, which has not actually been deliberated on before and are not part of the initial round of consultations, become a key part of the provincial processes. So even if it means trying to brief them outside of the hearing process, making written submission, writing multiple op-eds, every group that is working on a different technical or transparency aspect of the bill, I think has to really use this opportunity, because the indications from the Department of Health, DDG, or the person in charge of NHI, Dr. Nick Fitzgibbon, he was on radio a few days ago, and he said that the NCOP process will be wrapped up by October. So that's very quick and such a important piece of legislation in South Africa. And so we are concerned that there may be some pressure being put on the NCOP to rush through this process. We're not sure, but that will open itself up to legal challenge later. But basically, at the point at which this goes back to the president, we need to make sure that as many questions as possible are answered and as much clearer drafted. I just wanted to show you that there's really a mismatch between what department officials are saying and what the actual provisions of the law are. So just something as simple as, you know, a question on how is the department going to prevent political influence? But they said it's same as in any board, and you make it as autonomous as possible. But yeah, the way it's drafted, the bill currently, far from as autonomous as possible. So let me end there, and yeah, over to Andy. Thanks.
Thank you very much, Fatima, for that really comprehensive overview. I think the really important thing for us to get our heads around is the fact that this is not a switch on, switch off situation. We can't go from no NHI to only NHI. There will have to be this protracted process where there'll be multiple groups sitting. Now, I've seen one question already from Rajesh Patel. Have they made changes to the SEP provision? The SEP is often far higher price than the tender price for procurement by the provinces. And I think that really speaks to one of our core concerns. At the moment, medicines in this country can really be put into two entirely mutually exclusive boxes. What is procured by the state, actually bought by the state and then given to patients, is bought on a state tender system. And that price is the result of competitive bidding, or if there isn't a competitive bid, a negotiation process by the department. That is a transversal tender, so it is used not only by the 9 provincial departments of health, but also by the Department of Correctional Services and, at the moment, the National Defence Force. But entirely separate is the private sector medicines process, and there, manufacturers are free to set a launch price at any level that they want. There is absolutely no provision at the moment that alters what that launch price is. Then there are only 2 interventions, a maximum annual increase, and then a dispensing fee, one set for pharmacists and one set for licensed dispensing practitioners. If we now have 4 boxes, what happens? Is everything that's bought out of pocket subject to a private sector pricing model? Is everything inside the NHI subject to a new model which can't be a tender? If you have reimbursement of, for example, every diabetic in the country, we can't have only one insulin bought, because then very quickly we will not have any competition in that marketplace. So it's very, very unclear. I wanted to stimulate some discussion by giving an example of a current conundrum. South Africa has 3 provinces where malaria is endemic, KwaZulu-Natal, Mpumalanga, and Limpopo. But more patients die of malaria in Gauteng than die of malaria in KwaZulu-Natal. The reason for that is that those are mostly, almost exclusively, imported cases. patients who present to hospitals in Gauteng have contracted malaria somewhere else, either in an endemic province or from across our borders. So those patients should in fact be advised on using chemoprophylaxis, on taking antimalarials prior to visiting a risky area, such as the country from which they originally came. So some of them would be migrant workers, some would be South Africans, some might qualify for cover and some might not. At the moment, if they wish to access malaria chemoprophylaxis and they can't afford to buy these drugs for themselves, or they don't have medical scheme cover, they're only able to access one option, which is doxycycline. And doxycycline is procured under state tender. However, doxycycline can't be used by pregnant women and it can't be used by children under the age of 8. So they are sitting in an uncomfortable position. Surely a child under the age of 8 who is traveling to a malaria risk area requires a basic health service, because that is a health service that will prevent the consequences that seem to be included in the definition of basic health services. If a public sector or private sector facility were to be able to offer that chemoprophylaxis, which medicines would they get and at what price would they be able to access those medicines, and what price would be charged to that person? Wouldn't fit under the SEP and it wouldn't fit under the state tender. We're going to get some very confusing pictures. So to come back directly to Rajesh's question, in the consequent amendments to other legislation that's included in a table at the end of the bill, there used to be an amendment to the single exit price, and it changed the definition from being the price paid by anyone other than the state to being the price paid by the NHI fund or any other purchaser. That entire change has now been deleted. So it no longer is there. So we don't have anything in this bill that talks to how prices will be set in NHI, apart from the fact that there'll be a committee that advises on those prices. But what is the mechanism by which that price is set? How will dispensing fees be handled? That is not at all clear in the bill. And Fatima, I wanted to come back to you for perhaps a comment on the way in which South African law is constructed. We generally follow enabling constructs where the bill covers, or the act as once it's passed, covers the basics. It enables secondary or even tertiary legislation issued, for example, by a minister as regulations or by a statutory body in the form of rules, or in this case, we've got the NHI fund and its directives. But there is a basic principle that says that you should not abuse secondary legislation in order to introduce new law. You have to stay within the bounds of the enabling provision. If we look at pricing of medicines and the components of those price, not only the factory gate price, but the price that is paid by the fund or by patients out of pocket after adding in the distribution chain costs and the professional fees for those who dispense those medicines, is there sufficient enabling detail to be able to judge whether a directive or a regulation or a rule is in line with the Act or not in line with the Act? What's your feeling at the moment about whether the enablement is explicit enough to be able to judge secondary legislation later?
You're asking me or the other lawyers?
Yes, I'm asking you to start before we go to the other lawyers on the call.
I think I'm gonna let Lauren come in here.
So Lauren,
Lauren?
Lauren Parumur, you've written with us on the issues of intellectual property. Your thoughts on the enabling construct of this law and whether, in fact, it is opening doors that are unclear as to what their detail might look like.
So Andy, I mean, I was busy typing, saying, and learning a lot, but I'm way out of my depth. But I suppose I can try and answer in a different way, which is, I think there are other things that the state could be doing to create an enabling environment, and it's not. And I suppose that's concerning to me. So I think Fatima posted that Dr. Chris, for example, in a recent interview said that the HMI, the Health Market Inquiry recommendations are irrelevant. And I think that's really, really problematic. I think a lot of resources were invested in that. It's I think the EU has done a health market inquiry and perhaps to some extent the US, but it's not the kind of thing that's typically done. And so I do think we need to move ahead with those recommendations, because it's another way of making sure that the conversation around this legislation doesn't become solely focused on dysfunctionalities and problems in the state. I think there are dysfunctionalities also in the private for-profit market in healthcare. The other thing that I'm wondering is it negligent of the government to not move ahead with the patents amendments bill, given that that might have an impact on costs of medicines? And then the third thing, which I think is a little bit tricky, is if we're emphasizing as part of our health industrialization strategy a move to local procurement, we are potentially looking at asking the government to procure medicines that might be locally manufactured, locally manufactured, but perhaps a little bit more expensive than the global price. And that politically is a kind of tough argument, I think, that we have to grapple with. I think it's worthwhile. I think it's important to have local manufacturing, but to explain to a health committee or a budget committee, treasury, how that is justifiable, I think will be a little bit complicated. Thanks.
Thanks, Lauren. Let me quickly focus on the single exit price and these 2 boxes that now become 4 boxes. And perhaps Bada, if you can unmute. Bada, you were involved very much in the early description of our medicine pricing in the national drug policy. Has industry, and you can speak perhaps on behalf of IPASA, but also with your previous policymaker hat, has industry got a clear idea of how over the next decade or more we will have a single exit price intervention for items not covered by the NHI, and at the same time something else different from the current state tender system that's going to regulate the prices for those products that are included in the benefit package at NHI?
Hi, Andy, and thanks for the opportunity and very interesting coverage of what Fatima referred to as B version and A version and so on of the NHI bill. There's really not much that has been substantial in the amendments that Parliament has brought about, which is very disappointing. Now, in terms of the pricing and the post-NHI, what the industry has focused on or is focusing on at the moment is to try to get to a situation where we will be able to differentiate between transparency of medicines pricing, which of course Treasury really supports and defends, and the Department of Health also defends. What industry, however, wants to have Treasury differentiate from transparency is an issue of visibility of pricing. And by that, what we mean is visibility of South African pricing to external markets. And that is where you have the situation where reference pricing, where South African prices are referenced by other markets. And that has led to companies being, if I may use the word, coy in offering better prices to those patients who are not able to afford the prices that are being charged. I'm afraid people often ask, why don't you just reduce your prices and then everyone can be happy? I think there's a lot more that's involved in this, but we do need to talk about differential pricing. And it's interesting that Parliamentary Committee on Health was actually interested in hearing more from the PTG about the concept of differential pricing. And that would really ensure that those who cannot afford the prices that are paid in countries such as the UK and others will be able to have the opportunity of paying those lower prices. In fact, you do have the situation where certain markets, which are economically at a much lower level than the UK, pay more than patients pay in the UK. So it's also interesting that the Health Markets Inquiry does have a section on the issue of alternative reimbursement models. And they believe that while this has not been widely implemented in South Africa, it is something that ought to be looked at. And once that's fully understood by everyone, and the pros and cons of ARMs understood by everyone, then that should surely take care of the proposed differentiation in pricing. I might have touched on a number of scenarios at the same time, but for me, the bigger question is, given the conundrum that we face regarding what NHI is not clear on and the kind of practices that NHI is going to prevent from happening, shouldn't we be insisting that the recommendations of the HMI be looked at with a view to having them implemented? Because in my view, therein lies the regulation of the private sector, as many I'm sure on this forum would have wanted to happen. And once that has happened, I think then we'll have a clearer view towards the leveling of the playing fields that would allow us to really look at the fairness of pricing. As it is now with the two kind of systems that we have, it's really difficult to have any clear view on what NHI wants to provide in the private sector.
Thanks, Bud. Yeah, before you go, can I just quickly challenge you on that one? One of the responses from government has been that the supply side regulator that was recommended in the HMI report is identical to what is intended for the pricing and the benefit package and HTA structures that are implemented in the bill, and that since those will apply to the private sector as well as to the public, in fact, they are implementing the HMI. Are we missing something fundamentally different? Or is it just that the HMI focused only on the private sector as if the current medical scheme system would be perpetuated, whereas the new system kind of is based on the assumption that eventually it will disappear?
Andy, I think if we look at any kind of mechanism within the NHI that appears to be what was recommended under HMI, for instance, the supply side regulator for health services, I think that would amount to a piecemeal implementation of the Health Market Inquiry recommendations. We do not need to look at them, have a wholesome picture. It does mention issues such as the practitioner payment models. It does talk about coding systems, and it has a lot to say around fee for service. Now, what the NHI bill does is just take something, just a little bit of that, and put it into this. And the context within which the HMI mentioned those mechanisms and proposed bodies tends to get lost in this whole NHI thing.
Thanks, Bada. I see Rajesh has got his hand up. Let's go to you first, Rajesh.
Yeah, just touching on this issue of the health market inquiry and Nicholas's comments recently. Unfortunately, when he says that, yeah, the recommendation like the supplier side regulator will be covered in the NHI, he's mistaken for one simple reason. The Act doesn't provide for generalization of whatever NHI does. Whatever NHI does, it will be for that fund only and not for anything outside of that fund. So I'm not sure where he comes from, and particularly at this point in time when the Section 33 is there, that at some stage the NHI will take over a lot of the scheme services, etc., and schemes will only offer complementary cover. So even in that scenario, you still would need protection of the public and some kind of pricing mechanism that service providers and funders can get involved in. Yes, the National Health Act could make provisions for such a thing where any kind of price that's negotiated by NHI becomes a national price. It's similar to the way the US operates, where the Medicare, Medicaid price kind of thing becomes the national norm of what's used by everyone. So, you know, I was a little bit we were a little bit disappointed with Nicholas's comment as if it's not necessary. He's looking at a very narrow view type of thing, whereas the industry is very much broader. And it's typical that the example you used in the medicine kind of thing, where it's now 4 boxes type of thing, instead of just what the NHI fund used to do. And I also posted a comment about the procurement and funding issue in the comment section.
Thanks very much, Rajesh. Bada, I see you've got your hand up. Do you want to come back?
Yeah, just to add on to what Rajesh has said, Nicholas also said at the forum sometime last year that the Department of Health is not bound by the recommendations of the health market inquiry. So anything that appears to resemble HMI recommendations in the NHI bill is purely accidental. So let's really not be fooled by what appears to resemble whatever has appeared in the HMI. Thanks.
Thanks, Bada. So I'm just looking at Rajesh's comment saying NHI should focus its role on funding, for example, EML via the tool like therapeutic reference pricing, while the NDOH and the provinces focus on procurement, as they do now. I think that's one of the big problems. Imagine if the NHI includes cancer in its benefit package, and those services have to be provided in current state facilities, as well as in private sector facilities. Where will the same medicines come from, and how will they be priced? The one is a reimbursement option. The other one is actual procurement and provision to people who are state dependent. And I don't think this bill is very clear that it is in fact speaking about reimbursement and not procurement as is currently done. Private hospitals don't own wholesalers for the simple reason that they buy direct from manufacturers. But at what price? Which price is going to be the one that is charged if the patient who's seen in the private hospital is being covered by an NHI benefit package? And remember that medicines are not exclusive to only one indication. The same medicine in the same facility might need to be used for and within benefit or outside of benefit patient. How will those medicines be priced on the way into the system? And how will they be priced to those who pay the NHI fund or the medical scheme or the patient out of pocket? I want to focus a little bit more though on either children or the issue of those who are in the country either undocumented or legal asylum seekers. And I wondered if either PHM or MSF would like to weigh in on those. Candice or Annalene, perhaps you'd like to weigh in on how you see the access to medicines for those two vulnerable groups. Candice, do you want to start? Or
yeah,
Candice, Annalene has handed the baton to you.
And I actually want to hand it back to her because I think from MSF, we honestly haven't also engaged a lot on like the NHI. Obviously have done, I mean, broadly on access to medicine. So it's still very much like a learning curve for us. And yeah, still have to get our thoughts on, yeah, just in terms of positioning. So I'm not sure if I can sort of weigh in much on this.
Thanks
So-
very much.
So we actually have
Annalene, yeah.
on Saturday to discuss our position on the NHI, so I might be out of line, but going back to just the mere basics of health for all, I cannot imagine an NHI not providing for people who need help and putting that at the core of the NHI. It's who needs it, and whether you have a document or don't have a document, we should provide it. But like I said, I'm way out of my depth in this conversation. I'm learning a lot.
Thanks. So we've got on the not on the panel today, but as one of the participants, Fatima Suleiman, who is actually in Rwanda at the moment, attending the first meeting of their pricing committee. Fatima, you were the previous chair of the pricing committee in this country. The pricing committee had two very, very straightforward tasks: the single exit price adjustment annually and the dispensing fee. And yet, even just those two components were subject to litigation. And that had to go all the way to the ConCourt before they were implemented. Is there sufficient detail to enable this pricing structure within the NHI fund to intervene meaningfully on prices? And then secondly, what's missing? Bardo's mentioned reference pricing. That's been on the cards for many years and never implemented. Is it likely to be implemented through this system, or is a lot more legislation needed before that becomes implementable?
I think aside from the legislation, there's some basic structures, Andy, that are missing. Can you hear me, by the way, because I'm not
Yes,
too sure.
perfectly.
Okay, so for me, the biggest issue with the challenges both in the court and also challenges in meetings with stakeholders has been the evidence underpinning the processes and quantums that we eventually come up with. So we don't have sufficient information about what should be a good return on investment for suppliers, basically, to be able to dispense medicines, to patients and so forth. Like, what would be a good reimbursement rate for them? What would be a fixed fee for them? Like they're sort of saying they want a fee structure. And we still have very fragmented information systems. So, the one thing, and I'm going to explain from the Rwandan context as well, because we're here doing a scoping exercise, and, we can walk into a pharmacy and access financial records here nationally. They all standardized, they give it to you in the same way. There's no issue about presenting that information. So the PPAC here, or the PC here, is much stronger in that they have access to that information. They can access it. They can work with the stakeholders to negotiate an adequate fee for them to be able to even survive or grow if they need to. But there isn't that kind of information system in South Africa. So I think that for me, my biggest concern as well is that whatever fixed fee they end up coming with as an NDOH or a benefit structure, and that they're going to have a lot of evidence and justification for that. Secondly, for me, is the fact that the pricing committee from its beginning, even before I was chair, was looking at a suite of policies, not just the single exit price. The single exit price was implemented as a immediate short-term gain, but there were other issues that were supposed to come in, like internal reference pricing, external reference pricing, pharmacoeconomics, if needed be, some sort of health technology assessment. But they all got stalled in the processes. And I think that, in a sense, that within the NHI bill, for me, my biggest concern is the fact that we're still doing the same thing again. We're sticking to the SEP as a single policy. And even WHO recommended guidelines tell you need more than one policy. There's a policy that up until a certain time will be sufficient, will manage prices or introduce more access and affordability. But after a while, it needs a combination of policies. It needs a combination of activities for it to be meaningful, not just, I'm talking about patients, but about all the suppliers in the system as well. So I think that that short-sightedness and that vertical approach of a single policy is still a concern for me within this NHI bill.
Thanks, Fatima.
Yeah, I don't know if there's any more you want to add, but I'll stop.
No,
there.
let me take Marlies. I see your hand is up, and then I'm going to come back to Fatima Hassan on process.
Thanks, Andy. It's coming to the issue of migration that you raised, and I think those working in the migrant health sectors are really concerned about the bill and the way that the many inputs that were made to Parliament from a range of social justice organizations were not taken on board. And I don't think the current provisions speak to the principles of public health. What we will be doing as a coalition of, there's a coalition of organizations under the banner of Collective Voices for Health Access. We'll be having a webinar next week, Thursday. I'll put the details in the chat, in which we will unpack the bill in relation to migrant access to healthcare. And it would be great to have people on that webinar as well. And then perhaps one question, Andy. I'm really interested in the legislative process through the NCOP, and if there are people on the webinar who can speak a bit about their experiences of advocacy and lobbying in that space, and where opportunities might exist. I know Fatima has spoken to it a bit, and it would be valuable to hear if of other people's experiences about what we might be able to leverage.
Thanks, Marlies. So I just want to quickly touch on Bada's last question that he put in the chat, which was about the focus on what is called local manufacturing. It's more importantly, local and regional manufacturing, because every single country is not going to be able to pursue its own sort of autochthonous approach. So what happened with the NDOH was that it issued a tender for the pneumococcal vaccine. It made a decision that it would consider different pneumococcal vaccines, so a 10-valent and a 13-valent, as interchangeable. And it would make its decision, therefore, based purely on price. Of course, there's a local production component to that, but the majority of the points in the state tender are based on the price. In this case, there was an interesting conflict because the state owns 49% of the shares in BioVac. It has spent many years providing BioVac with additional support through a distribution levy on all expanded program on immunization vaccines. But when BioVac had negotiated a license for the 13-valent vaccine and submitted that as a price, it was outbid by a Serum Institute of India product brought to the market in this country by Cipla. So the department was stuck with its own procurement rules. And it speaks to the difference between using procurement or even reimbursement as an industrial policy tool or having other industrial policy tools, such as tax breaks, for example, or other industrial investments. And I don't think the medicines budget is the right place to engage in industrial policy. Now, if we look at Australia's national medicines policy, it says that the policy of government is to be responsible and to ensure the long-term viability of the entire pharmaceutical distribution chain, not only thinking about patient access. So there is an argument for an all-of-government approach here, but it isn't as simple as saying that government should pay a premium and that should be the only mechanism by which industrial policy is driven. But I wanted to come back in the last 14 minutes or so to the process question, Marlies, that you raised. So the NCOP, with the Section 76 bill that was introduced in the Assembly, can either accept the version that comes to them, that would be the B version, or they can reject the B version, or they can propose their own amendments to that B version, and we'll get to a C or even a D version. The NCOP votes in this case per province. So each provincial legislature has to debate and provide a mandate to its NCOP delegation, and it adds 4 additional people to the 6 in the NCOP, and they come back to Cape Town to vote on the bill, but they vote only 1 vote per province. If, however, the bill that they approve is different from what was originally approved in the National Assembly, there has to be a conciliation process to meet in the middle, find something that both the NCOP and the National Assembly can live with, or alternatively, the National Assembly can overrule all the changes recommended by the NCOP, but only if they have a 2/3 majority in the Assembly. Now, if we look at the amendment to the Constitution in terms of expropriation of land without compensation, they failed to get a 2/3 majority. And given how the opposition parties have spoken on even the B version, it's unlikely that they would be able to get a 2/3 majority in the National Assembly. So there is the opportunity in the NCOP to provide a C version. And if the C version is different, that could go back to some sort of conciliation to come up with a final version that could be adopted by the Assembly and then sent to the President for assent. Whether those provincial legislatures will feel comfortable enough to provide a mandate without extensive debate and even public hearings in each of the provinces is as yet unclear. But as Fatima mentioned, the original hearings were on the first bill as tabled, so Bill 11 of 2019. And so the provinces have not debated the B version. And there's been no engagement with the population and the general public or any stakeholders on the B version. We've only seen it coming out of the National Assembly having been adopted on the recommendation or on the majority vote of the Portfolio Committee, with every one of the opposition parties represented in the PC voting against that version. So I think there are opportunities for engagement, but we're in new territory. I don't think this has been seen before, but what we do know is that if a bill does not provide for sufficient public participation, that alone can result in it being declared unconstitutional later. And we've seen that a couple of times now from the Concord. So Fatima, do you want to, Hassan, that is, do you want to come back on process and where you think the opportunities lie for civil society to engage with the NCOP process from now on?
Yeah, so look, I mean, I don't want to be alarmist, but I think we're facing a crisis, right? Says the person who says they don't want to be alarmist. So if you think we in a serious crisis around the cost of healthcare provision and the cost of medicines in South Africa now, I think we're going into, to use your words, even more uncharted territories because it's so unclear. And I think alongside the partisanship, the political parties' responses and behavior and defensiveness, and the opposition parties sort of, building of their own narrative. And you saw the IFP at the National Assembly stage, they decided not to vote in favor of the bill. They went supportively at the committee level. So there's obviously a lot of political considerations. So there's all this, the politics are happening in the next few months, while a number of legal risks and challenges, and we having to somehow decipher what we can do within that space as academics or civil society groups or people who are interested in the future of proper, affordable, timely medicine access in South Africa. Because the way they've drafted it, it continues being a piece of jewelry. It's what we've said, right? Medicine should not be a luxury. And they're still creating these 2 or in fact 3 systems where if you're rich and you have money or a job or a medical scheme coverage, you can just buy up. And so too can MPs. And so the the part of the medicine system, access pricing system that is unregulated, is untouched for the foreseeable future until the minister decides NHI is fully implemented. And I think that's part of the problem. And there are vested interests from the private sector who have stalled all the legal reforms, who are not interested in international benchmarking, and they have no interest in trying to make the system unified, transparent, fair, and affordable. And I think we have to be open and admit to that. It's not just about government failures in trying to bring about a suite of policies that Fatima was talking about. Every attempt to try and get price transparency or procurement transparency is met with a lot of resistance. We are having to go to court on the 24th of July to open up the vaccine contracts. Yes, there may have been an exception in COVID, but those companies have created this precedent. You want our supplies and you want it at the price we're giving it to you, then you sign a non-disclosure agreement and it's done in secrecy. So there's many elements, I think, of how we are going to have to try and intervene in terms of using the available process, which Andrew explained is important. But my question is, with all the politics, with all the legal risks, with all the vested interests, with all the government dysfunction for a number of reasons, and you can all have your own views about what created that, how do we advocate and what would it look like? And some really, grateful to Rajesh and Bada and all of you for your views, but what would a single medicine pricing system for South Africa look like, even with the NHI, which regulates both NHI prices and non-NHI prices, and one day the prices for that top-up cover? Because the state is never going to be able to afford all the cancer treatment, right? Whether it's a wastage of resources, whether it's competing demand. I mean, there's a number of, probably 100 reasons why the state is never going to provide the best that science has to offer at the time when it's being offered. So there will always be people who are buying up. How do we also regulate that part? And how do we start making those arguments? Now, is it possible to have, and I think Rajesh talked about that, is it possible to have a single pricing structure for whatever model is operating so that you actually regulate that space in a context where there are limited funds? So that the transparency is not just on the health products procurement unit or the NHI fund or the board, but it's also on, like you mentioned, the launch prices, the role of manufacturers, the role of suppliers. Because I think I want to tie it up to the reason why I'm asking that is it goes to that very, people regard it as weird or odd decision, which the minister was really embarrassed about around the BioVac and serum supply. And it was announced at the time when they were having the big mRNA meeting in Cape Town. We said, well, we didn't have a choice. We have to do it. And it was cheaper. And also, we're now amending our procurement laws to have preferential procurement frameworks in place. So by the time the NHI is implemented, assuming there are no legal delays, then there's going to be a preferential procurement framework, which may actually give effect to what Annalie was talking about, not just in the mRNA vaccine space, because that's the concern of BioVac and Afrigen around that particular hub, but I think it extends to other products as well. Around, if you have limited resources, do you still, take a local regionally manufactured product over something that's more cheaper? And that's the battle we had with ARVs in South Africa. So all of that to say, it's so complicated and so difficult, and really not sure how we make the best possible set of recommendations to the NCOP, because our view just on process is we make those recommendations, we try and make submissions, we try and get to be invited to hearings, we try and insist that there are hearings so that if it does go to court, we have an evidence trail of the public attempting to engage on these issues, from the beginning and not just sort of at a later stage. So thanks.
Thanks very much, Fatima. Let me give anyone who's got one last comment to make before I have a summing up. Anyone like to put their hand up for one last comment? I see some claps from Bada, but not a hand up. Is that a hand up? That's a hand up. So you're clapping yourself. Okay, Bada. Last
Probably
gasp.
because I have two points, two very quick points. When I was in the Department of Health, we were interested in cheap medicines. The then Department of Trade and Industry was interested in building a strong manufacturing economy local. That is still the case, and the two are not talking to each other. In India, when a company wants to export, they get certain incentives, such as being told by government, if you go and set up your factory in a very low cost area, we'll give you some incentives because you'll be providing employment there, that type of thing. But it seems to me we need some kind of super ministry that's going to bring all these departments together so that they can do the same thing. And then on the question that Fatima raised, do we need to have a unitary pricing system for the whole country, whether it's NHI or not? I would add, or differential pricing system. I'm not sure that one is qualified to give a definitive answer to that. What I do think is that we need some type of forum, a forum that's going to go on for some time until we have the answers. That will include at least the funders, the manufacturers, the patient groups, and government. And let's see what comes. We need to get together, and we need views that will finally result in some kind of compromise position. I don't think we have anything that can be adopted at the moment. Thanks, Andy.
Thanks, Bada. So just to sum up, we are now in an interesting position. Many headlines told us NHI bill passed. Not quite. We've got a version that has now moved from one House of Parliament to the other. We have a complex process under Section 76 of the Constitution to bring this to conclusion. In the NHA, in the National Health Act, we saw a definition of municipal health services that cut through years of confusion, gave us absolute clarity of what was the responsibility of local government and what was not. I'm afraid the definitions that we see here, including basic healthcare services, are not sufficient to give us that clarity. And that runs right through this bill. There is a lack of clarity on processes, on structures. There's a move, but you can almost see decision makers being dragged slightly away from what their preferred original position was. It's not the minister. Okay, we'll make it the minister plus cabinet. Still not enough. That is not open and it's not transparent. But I think Bada also raised something that tells us of the complexity of this entire field and perhaps where vested interests are very, very difficult to deal with. He was talking about the contrast between transparency and visibility. And he seemed to imply that we could have transparency without visibility. Now, transparent invisibility is, I think, something I'm going to battle to get my head around. But it really talks to the complexity of this process. Our Constitution says when the state or any state entity procures, that should not only be done in a fair and efficient way, but in a transparent way. And NHI should be no different. All of these processes should be open, transparent. And I therefore invite you to keep an eye on the HJI website for the exact date of the May session, because our third webinar will focus on monitoring and evaluation, transparency and accountability. And I think we've raised today just around medicines access, benefit package design, formulary design and management, and procurement and reimbursement, how little we know about how those will be done transparently and with accountability, let alone how the data systems will work. So thank you, everyone. Thank you, especially to Fatima Hassan for taking the trouble to do that very extensive run through some of the most important. And thanks to everyone else who's joined us today. And I look forward to seeing you at the next of our webinars, accountability. transparency, monitoring and evaluation. That's going to be a monster ask. Thanks very much. Fatima, last word from you. Fatima H, not Fatima S.
Just thank you for moderating. Thank you all for joining. And we are meeting in July, not May, Andy, because May is already over.
Sorry, did I say May? July.
Yes.
Correct.
Which beer are you sampling there in Europe? Andy?
Oh, you know, the Swiss make the most potent of the lot.
Yeah. But
Thanks, folks.
just Andy, I think that if anybody is interested in joining us on a joint submission to the different provinces of where you're based, or maybe where you have influence, I think we can repeat the same submissions to every provincial legislature. We'll be working on that so that once the dates come out, we're ready. Then just pop us an email, and yeah, we'd have to work with a number of groups together, because we're trying to show that there's a broad range of actors that feel the same. We really want equity in healthcare in this country, but we are not aligning ourselves with a political party who either just embraces it or just rejects it. But we're trying to show the evidence base for why we are agreeing or disagreeing with different aspects. So we look forward to working with you all. Thanks.
Thanks, everyone. Bye.
Thank you. Bye.
Bye, guys. Oda, you have to drop me an email.